Good morning. My name is Chris Bateman. I'm a healthcare journalist, former news editor at the South African Medical Journal from 2000 to 2016. I've worked with BizNews for about 3 years, and I'm essentially a freelance journalist. My guest this morning is Henru Krüger, the sector head for professional guilds at Solidarity, which is well known to BizNews readers and listeners. But for those who don't, it's a voluntary occupational community of professionals in the healthcare, legal, and financial sectors. Morning, Henru.
Good morning.
Henru, we're talking about a very long-standing, controversial subject or piece of legislation. We'll find out later at where it is in the process, in the pipeline. But it's called the Certificate of Needs. Now, it's basically going to tell doctors where or when they may practice. So hence the controversy. The Director General of Health or their designate will have to apply his or her mind to a host of requirements before issuing a certificate. This will range from consistency of health service development in terms of planning, equitable distribution and rationalization of services and resources, including existing public and private facilities in an area, and correct racial, gender, economic, and geographical imbalances, taking into account the demographic and epidemiological characteristics of the population to be served, plus furthering the Employment Equity Act in emerging small, medium, and micro enterprises. Now, that's quite a mouthful, but essentially, it's arrogating to the Director General the authority to tell healthcare professionals where and when they can practice. Now, sketch for me what you see as the purpose of it. It's highly contested since 2014 and before, and it's long drawn out progress to where we are today. And of course, the thing that's driving it all is the government's constitutional obligation. It's founded on a constitutional obligation of furthering equity in healthcare. So just introduce to our listeners how you see it before we go into the pros and cons.
Thank you, Chris. So for me, the most simple way to explain it is there is an existing need for healthcare in certain areas, and maybe there's not a healthcare service in that area. So in South Africa, that's quite prevalent, especially where the state clinics are allocated at, and that would be in townships. So most of these state clinics don't have a visiting doctor to these clinics. About 75% of them do not have doctors that attend to these clinics. And, these are community care clinics. So the community would go to such a clinic expecting to receive healthcare services. And most of the times, they won't be able to access healthcare services in those areas. So
Right,
this
so
is...
Go ahead, sorry.
Yeah, so this is a problem in South Africa, and it's based on racial lines, it's based on provincial lines, and even the sort of healthcare facility that you attend to. So there's quite a discrepancy between the private sector and the public sector.
So in a way, you can say they're trying to bring doctors to the people instead of bringing people to the doctors. And of course, that brings in the whole technology debate. But let's just go back to the legislation itself, because, doctors have been skitsy about this for a very long time. And then it was put on ice for a long time. And when I first reported, I spoke to the DG about it. And then it was revived in the Zuma era. And now it seems that it's fast forwarded to becoming quite a present moment reality. Where are we now in the time frame?
Yeah, so under President Zuma, it was actually promulgated. It's Section 36 to Section 40 of the National Health Act that actually regulates the Certificate of Need. So it was promulgated by the minister. And the problem with that process was that the regulations wasn't passed together with the promulgation of the legislation. So the state legal advisors actually advised the president to approach the Constitutional Court to stay the implementation of Section 36 to Section 40 of the National Health Act.
Because otherwise it would have actually rendered all these practices illegal, because they hadn't actually thought through the timeline in terms of what they need to do. It's quite a logistical, call it nightmare, to actually make it happen. So it was quite clumsily introduced. So, you ended up with the president taking his own legislation, or his health legislation, the Constitutional Court, to try and remedy the fact. So what was the outcome, and where are we, and lead us up to now?
Yeah, so like I said, the implementation was stayed, and the Constitutional Court said it was irrational, to actually promulgate it without the regulations. So at this stage, the regulations have now been published for public comment, and the public had time to comment up until the 15th of August of this month. So now the question is, when is this going to be implemented? And as we read the legislation, the Minister of Health can actually promulgate this. The comments that he has received, he can now work into the regulations. And then actually the legislation says that as soon as that has been published, within 3 months, it will come into power. So at this stage at Solidarity, we have consulted with our legal advisor, and we have drafted a letter of demand to actually now stay this implementation. So, if it's going to be implemented within 3 months, that's going to push this huge obligation onto healthcare practitioners, as you have mentioned. And all the burden of proof is going to be on them to actually prove that they are to be allowed where they are currently practicing.
Right. I remember speaking to the DG at the time, 2014, and this was Precious Matsotso, who's now gone to the WHO. And she was saying, no, you can reassure your doctors, your readers of the SAMJ that we talk about a grandfather clause, that we're not going to tell practices that are existing. It's people coming into practices and joining practices who have this need. I mean, everybody has to apply for certificate need, but they get more lenient on existing practices. The idea is, I imagine, over time, to get a demographic spread of healthcare services so they can meet their constitutional obligation. But the devil obviously lies in the detail.
Yeah, so that's the problem. We can't go according to what the interpretation by the Directorate General is. I also was part of a grouping of general practitioners that actually met with Precious Matsotso, and she was quite accommodating. She spoke to us, and we had some concerns that were addressed. But this doesn't go into the regulations. At this stage, the regulations doesn't differentiate between an existing practice and a new practice. So even existing practices will have to prove in writing, in duplicate, to the relevant municipality and also the relevant state departments why they are to be allowed to be practicing where they are practicing. So this is quite concerning. There's no differentiation being made. And like you've said, Ms. Precious Matsotso has moved on. So you can't go according to the interpretation. You must look at the letter of the act.
Well, yeah, it's like some of the legislation passed the time when Madiba, Nelson Mandela, was president, and the presidents that followed were given kind of unfettered powers. It's a similar kind of thing. It depends on who the incumbent is and how they play it. What I was quite interested in is that Debbie Pearman, she was a former legal advisor to the National Minister of Health. She herself has been very critical of it. She said that health services are generally located where there's a strong likelihood of patients finding him, and yet there was no cohesive plan at national level to manage healthcare demand. Instead, a disproportionate emphasis was placed on the proposed CRN, a supply-side management tool. She says it's possible to filter patients through primary care using technology, telephone advice, interactive information services, sharing knowledge, community agencies, and the location of doctors' practice, particularly those specialists, would always depend on the proximity of technology, whether this was the basics of electricity and running water or a private lab. She says, and I quote, "No private provider can logically be expected to set up a practice or a hospital in a place where there is a scarcity of patients and in the absence of other incentives." She says there are less restrictive ways to bring healthcare to rural and underserved geographical areas. They include improved working conditions, incentivized employment, subsidies, rural allowances, tax rebates, plus ensuring the healthcare providers in rural areas could more easily earn CPD points. That's just an interesting thing coming from where it does.
Yeah, that's true. If we look at the medical schemes networks, they are completely aligned to medical scheme members. So medical schemes also utilize certain organizations and associations to service their members. And when you look at that, like I say, that alignment, the doctors are where the members are, and they know that they're going to be paid. They sign these contracts, and there's no problem. That's why I actually just focused on the public sector, where this is not happening. The clinics do not have doctors because there's serious problems. Doctors do not want to go and practice there. It's not safe. In the first instance, there's no medicines there, so they can't actually treat patients. It's not conducive to a good healthcare environment. So that's the problem. And on that point as well, we had a huge health market inquiry that did an inquiry into the private sector, medical sector. And nowhere in the recommendations of the health market inquiry report do you read anything about a certificate of need. If it was such a big issue, and if this was the solution, surely the health market inquiry, spending all that time and all that money with all those amazing minds that's been applied to the private healthcare sector, would come up with the solution being the certificate of need. There's a few other solutions, and we can talk about that a bit later.
Sure. And I mean, it's not like there's an overlap between when the health market inquiry was operating and when this legislation was being discussed and forward. So yeah, I mean, one can, again, horses for courses, but it is a legal instrument widely used throughout the world, and there's a constitutional obligation for progressive access to healthcare in South Africa. But in the United States, they've used certificates of need, but it's subject to regional framing and properly adapted. You could ask, why is it in our particular South African context so inappropriate?
Yeah, so I've extensively looked at the certificate of need in the United States. They had a similar health market inquiry. They're 10 years ahead of us. And the Competitions Commission actually in the US said, that they believe the certificate of need shouldn't be implemented. We had federal legislation that actually, made a certificate of need compulsory. That was also done away with. And immediately after that, 10 states immediately dropped the certificate of need. At this stage, as far as I'm aware, 35 of the states are still implementing certificate of need. What the Competitions Authority actually found, that the three main purposes of the certificate of need was not served. And the first is access to health. It actually restricted the delivery of healthcare because fewer healthcare practitioners and service deliverers actually got into the market. The second one is the cost of healthcare. It actually went up a lot. The cost got a lot more expensive. And then thirdly, and I think most importantly, is the quality of healthcare actually dropped. So that was the finding in the US, and it won't be any different in South Africa. It will restrict.
Well, we do have somewhat different contexts, but yet you do say that 35 of them did implement it.
Yeah, so in the US, their funding model is substantially different. In this instance, the certificate of need, there is not enough funds. I mean, the healthcare delivery system in the US is the most expensive in the world internationally. They have substantive resources, and for that reason, I think certificate of need can still serve a purpose in those states. Specifically in South Africa, the problem is, like I mentioned, according to provinces, we have provinces that's not as strong as other provinces, especially looking at Limpopo, for instance, in Mpumalanga, the Northern Cape, Eastern Cape, we now see with the COVID pandemic, Livingston Hospital now again referring patients away. You know, it's not the same as a first world country. We have scarce resources. It's not going to serve us.
Just picking up on the scarce resources. I mean, we've had endemic corruption for a very long time. It's starting to be addressed. Many people in orange overalls just yet, but on top of that, we've had COVID for over a year now, and we haven't actually begging bowl out to the World Monetary Fund yet, but we've been downgraded in status. Just talk to, because again, this comes back to, because this is, I think, what listeners, many of them perhaps don't understand, is that it's part of the panoply of the NHI. This is very much part of that whole thrust. You're going to have the Office for Healthcare Compliance Standards look at these facilities, and part of the accreditation and licensing will come through them. So it's kind of a huge bureaucracy, and it's going to be incredibly costly. I mean, just talk to that, because historically Solidarity have been very anti, I would imagine, the NHI.
Yeah, so like I mentioned,
from the moral point, morally everybody agrees it has to happen, yes. But it's again, how and can we afford it? And this is part of that.
Yeah, surely. I mean, we can agree that universal healthcare, is necessary. And at this stage, like I say, in the private sector, general practitioners are serving their patients very well. If we said that these general practitioners in private practice have a lot of capacity, there would be sense in bringing in a certificate of need, bringing in patients, but they don't have that capacity. The problem is we don't have enough general practitioners in this country. It doesn't matter how you shift them around, social engineer them, or where you send them to. There's not enough general practitioners, and that's mainly a problem that, we can't train doctors in the private sector. They must be trained in the public sector. There's certain quotas put into medical schools. So we need to get more doctors trained. That's the only solution. Medical schemes use the same doctors. Like I said, I spoke to most of the contractors for the state trying to contract doctors to work in state clinics. And the problem is, we never had an NHI contract. The budget was there to actually contract with private sector doctors, but the state want to employ them. They're not satisfied to employ or to contract with private practitioners. They want to employ them and be prescriptive in what the doctors have to do, just like they are prescriptive in training these doctors. And I mean, you can't push this constitutional obligation in terms of Section 27 to provide access to healthcare to a private practitioner. It's not fair to put this huge obligation onto a private practitioner that has to see. I mean, under the NHI, there's been projections. You'll have to have 12,000 patients under your care. It's not going to serve the quality of healthcare that you have to deliver. I mean, it's ridiculous. 1,000 patients to a doctor is already a tall order. I mean, now you're pushing 12,000 patients to a doctor, but the state is not there. They're not there where they need to be into contracting with private practitioners. Now they bring in the certificate of need, and it's conflicting constitutional rights. I mean, you have to now give access to healthcare in terms of Section 27. And under Section 27 is also the right to food and to water and to social security. And now we've seen this green paper on social security. It talks about 12% increase in tax. NHI is going to bring about a 20% increase in tax. And I mean, that's for all the taxpayers. But the service delivery is going to be pushed down onto private practitioners, GPs at this stage, 6,000 GPs. I mean, it's not enough to go around. You're going to restrict the delivery of healthcare. It's going to be an even further barrier of entry to the profession. And then, I mean, the constitutional rights of freedom of profession, freedom of association, that's being trampled on. Section 25, the right to property is going to be affected. And then, I mean, competition is going to dwindle, and you're centralizing a dysfunctioning bureaucracy. It's not going to work. Not even Discovery Health can do this. Not even GEMS can manage this. So it's not going to work under state control.
If we just push to one side, the legislation at the moment, and we look at what you're saying is this is not implementable, but put all of that to one side. Are they paying doctors, the ones that they're going to contract in, enough? Are they, it sounds to me like the doctors don't really want to come to party. They're going to get paid less for a lot more inconvenience. Just talk to that.
Yeah, I can maybe just mention I was part of a 6 weeks program called the Ideal Clinic Realization. It was actually mandated by President Zuma. It was based on the big results fast model of the Malaysian government. So we did all the costing together with National Treasury. And if you go and look at the government pay scale, it's very good. I mean, it would be lucrative for doctors to actually work for the state. Like I said, the problem is you go to these clinics, there's no medicine, it's not safe. You get mud on your way to work. It's not there where these healthcare practitioners have children, they are married, they have to see their children going to school. They need to be like Dr. Debbie Piermain said, they must be able to do CPD points. This is the problem. It's not healthcare practitioners not willing or just looking after money. It's not conducive for them to be working in these areas. If I can just maybe mention, in Canada, they use South African doctors, young South African doctors going to Canada. My nephew was one of them. He worked in an Indian reservation there where it's bitterly cold, where no Canadian wants to work. They utilize these doctors. At this stage, we have 400 foreign-trained doctors that can't get licensed to practice in South Africa. 400 doctors that could be utilized in these areas.
Yeah, that's a whole other.
Yeah,
that's a whole other can of worms involving the Health Professions Council and their dysfunction to this point. They claim to be reforming the whole thing, but these are desperately needed skills which we're not utilizing. I understand there's been corruption, there's been false registration of foreign doctors, and they're trying to clamp down on that. They need to put a microscope on it, but nevertheless, one would think that they would speed it up and certainly take every bit of skill that we can get because we so desperately need it, because we've got such incredibly ambitious plans. A devil's advocate question, and doctors won't like me for this. I've been writing for them for over a decade, but aren't private healthcare practitioners so historically accustomed to the hugely skewed access to healthcare that they've failed to see the vital necessity for these kinds of measures?
Yeah, I mean, it's a good question. Doctors practice in the way that medical schemes require them to do. So a lot of the sort of customary ways of practicing has been brought about by the benefit design of medical aids. So you have to see a patient for a very short span of time. You have to dispense medicine and you have to move on to the next patient because it's a fee-for-service model. So, and every year, these increases don't keep trait with medical inflation. So every year, doctors are paid less. So they have to see more patients to actually survive. This is a really unsustainable model, and it needs to change. I mean, that's why the health market inquiry was conducted. There was a lot of good recommendations coming out of that, and we could actually implement that and make the private healthcare sector, we can fix it and we can broaden it and give access to more patients to come in.
Henry, just a question, how is it going to affect? I mean, you've spoken to your doctors that are voluntary members. How's it going to actually affect them? Bottom line, a question in this country always is the law of unintended consequences. Just outline how you see some of those.
For me, the most important thing with the certificate of need and the NHI, and for me as a patient, is the relationship between the patient and the doctor. So the patient must be involved in his healthcare. He must make the decision. He must make an informed decision, and the doctor must advise him. And then also you have the right to get a second opinion. So this whole relationship is going to be shattered. I mean, if there's somebody that's the payer, and at this stage, the medical schemes are quite involved in that relationship between the doctor and the patient, and it's getting, like I said, unsustainable, unattainable. It's not nice. Now, if you have a funder like the government looking over your shoulder, being in that relationship, telling you which medicine, what sort of treatment, where this treatment must be accessed, it's going to take away your ability to take control of your own health, make your own decisions, and make a difference in the outcome. It's completely going to take that away, and that's my biggest concern.
Put another way, you could call it Big Brother medicine.
Exactly that.
Okay. So, I mean, there's enough historical evidence to back your contention that we've got a somewhat dysfunctional public healthcare sector. And we've seen, I mean, in the East, we take one province, look at the Eastern Cape. I mean, they're not going to have enough money to make budget by September, apparently. It's crashing and burning. Now, that is similar in other provinces. I mean, the Free State itself was robbed blind. So you've got that. But, okay, so situation, we've got this ideological thrust. What's the alternative? There's a constitutional obligation the government has to meet. How else can we do it? Talk to me fairly briefly in the time we have left about that. And then perhaps I'll add the last question to it. Does it not all boil down to competing constitutional rights, and it's going to end up in the Constitutional Court? Where is this going to end, and how is it going to be resolved? And then what's the alternative?
Okay. Yeah, so a few organizations, including us, has proposed a voucher system. So you get a voucher from the government that you can spend at a healthcare practitioner of your choice, and built into that voucher would be certain healthcare services. So a basket of services that has been priced, and that voucher will be accepted by a healthcare practitioner. So you can actually go and access health at your practitioner of your choice, and built into that voucher will be the healthcare services that we need. That addresses a need, So it is going to end up in Constitutional Court, because Section 25 is just as strong as Section 27, and Section 22 and Section 20, which is the freedom of profession and freedom of association. These are all constitutional rights. So in the end, it's going to be a balancing act. It has to be a balancing act, and this is going to be happening in the Constitutional Court, but it has to take into consideration all the work that has been done with the Ideal Clinic Realization Program, the Health Market Inquiry Program, international examples like in the US, like in Canada, like in the United Kingdom with the NHS system. It's not easy. It's going to be difficult, and it shouldn't be done in a court. It should be done by the stakeholders within the healthcare sector. It's been done now in the private sector. Dr. Aaron Matsuleri specifically excluded the public sector from the health market inquiry, which is very bad. It should have been included. Then we had a complete solution at this stage.
So we're looking at ending up in the Constitutional Court. Now, Solidarity doesn't actually budget for, hiring senior counsel. And who are you going to take on board to fund and to make this challenge more effective?
Well, we have a substantial legal fund, a lot of contributors to that fund, like-minded people with Solidarity. And of course, we'll work with the associations. The first time in court was the South Africa Dental Association and the Hospital Association of South Africa. South African Medical Association is opposed to this. I've seen a letter that's been written to the president that basically contain all the professional associations, medical associations in this country. So
private practitioners as well.
Yeah.
Henru, listen, thank you. You've thrown a lot of light on what's going to be a thorny topic and what's not just affecting doctors, it's going to affect all of us. It's going to affect healthcare delivery. And we can only hope and pray that the Constitutional Court, in its wisdom, with the right advice, will come up with a solution that the voucher solution sounds like a workable one. But it's going down to the wire, and we're going into September, and by Christmas, do you think, where do you see a resolution lying? Perhaps as a last final answer.
I think within the next 3 months, when this regulation should be enacted, we're going to push the legal route. If government wants to come to the table and discuss this, there can be discussions. We have enough knowledge on our side, both from financial and from the clinical side, from the medical side. We've done our homework, and we ask people, like you said, it's affecting all of us. Please support and please join if you can. If you're a professional, you can join the Solidarity Guilds and stand, together. And let's make South Africa better. Let's achieve universal healthcare the correct way, not with a political agenda or an ideology, but let's do what's the best for all of us.
Do we have to wait for the regulations to be promulgated by the health minister before you mount the legal challenge, or not?
No, we are not going to wait for that. Like I said, we have written a letter of demand. So in our comments, actually from our senior counsel, we have advised the minister and the DG to actually rewrite the regulations de novo from fresh, because it doesn't make sense. It's irrational and it's unconstitutional, both substantively and procedurally, because this is an administrative act, passing regulations. We know that this has been set in law. It's an administrative action. It has to be just, and at this stage, it's not substantially or procedurally just. It's irrational.
Well, it's fascinating because it's not only affects the medical fraternity, it affects the wider public in a fundamental way. So the battle lines are drawn. Henru Krüger, thank you for your time. Let's see how it plays out. Okay, this is Chris Bateman, News Radio, signing off. Thank you so much.